I want to welcome you to the last session of this very successful AAFE Nexus event during National Public Health Week. I'm Jan Warren Finlow, Professor and Interim Chair of the Department of Public Health Sciences at UNC Charlotte. My preferred pronouns are she and hers. Even though we're not actually on campus today, I want to acknowledge that UNC Charlotte is located on the traditional homelands of the Catawba Nation, and I honor the lives and sacrifices of Indigenous peoples everywhere who have been and continue to be oppressed by white majorities. Our session today focuses on social determinants of mental health during and after the pandemic, a topic I'm sure that we can all relate to both personally and professionally. Our panelists are a mix of eminent scholars and frontline mental health providers. First, we have Dr. Rob Kramer, Associate Professor and the Irwin Belk Distinguished Scholar in Public Health Sciences at UNC Charlotte. Dr. Kramer was awarded the American Public Health Association National Excellence Award in 2020 for his research on suicide prevention and mental health. In terms of providers, we have Mr. UJ Harris, who is the president of Psychology for All, a nonprofit agency providing mental and psychological services to the Charlotte-Mecklenburg community. And on the front line, we have Ms. Elise Howell, who is a licensed clinical mental health counselor at Psych East, where she counsels adolescents, couples, and adults. And lastly, we have Dr. Annalise Menike, who is an assistant professor in the School of Social Work at UNC Charlotte. She works to prevent intimate partner and sexual violence through trauma-informed interventions. And Rob is going to start the presentation now. Please put your questions and comments in the chat.
Well, thank you, Dr. Warren Finlow, for that kind introduction to the panel. And thanks everybody for being here today. Just to orient you a little bit, I'm going to provide just a brief overview of a joint effort between UNC Charlotte and Psychology for All from the summer and early fall of 2020, which was a needs assessment in the area of mental health and some.
Rob, you just went on mute. Yep.
After that, each panelist will provide some thoughts, and then we'll open it up to a Q&A. So again, as Dr. Warren Finlow mentioned, we're very lucky to be joined today by a number of panelists. UJ Harris, Annalise Menike, and I partnered together with several other members of our organizations in the spring and summer of 2020 to do a joint needs assessment for low-income adults in the Charlotte region. And our backdrop was this very idea of social determinants of mental health that we were approached about to talk about today. For those of you unfamiliar with this kind of a framework, it's really a top-down public health model where public policies and social norms shape structural inequities that then result in things like poverty, inequitable access to health care, rises in child maltreatment and other forms of violence that then directly impact things like our stress levels and poor mental health. Now, layer on the context of a pandemic, and as you could probably imagine, a lot of those things are amplified. We know, for example, nationally, that mental health rates and diagnoses are up. Domestic violence incidents are up. So I think those things really framed what we wanted to do, which was to understand what this looked like locally for the most vulnerable in the Charlotte region. So in the spring and summer of 2020, Psychology for All in UNC Charlotte conducted a joint needs assessment of low-income adults in the Charlotte and surrounding region. So Charlotte-Mecklenburg and its constituent counties. And as I walk you through this, what you'll see is that we took an assessment of COVID-19 exposure, so perceived and known exposure to the virus, but as well as stress and reactions to the pandemic, I think, which really starts to speak to some of the psychosocial impacts. We tried to be comprehensive in mental health and alcohol use, and you'll see the specific categories. We also wanted to assess resiliency and some of the social determinants such as relationship quality and domestic violence experiences. Looking forward, we also wanted to assess interest in and willingness to use both online and virtual mental health services, which of course feeds directly into Psychology for All's mission. This is an online survey distributed through Psychology for All's constituent partners listed here, and the eligibility criteria for the survey are here for you. If you have questions about the methods and procedures, we're happy to answer them, but where I really wanted to center our focus today, we're on the goals and some of the key findings from this needs assessment. I'll also mention that we have a full needs assessment report, the short version of which is posted to Psychology for All's website, and the full report, which is available from UJRI via email. So our goals with this needs assessment: to assess the immediate exposure and impacts of COVID-19. So I'll walk you through what those stressors and responses were in the following slides. We also wanted to assess some of the psychosocial impacts, namely mental health, alcohol use, domestic violence, relationship quality, and other coping related efforts. I think coping efforts is going to be a key theme here today, especially as we move forward in thinking about what can we do from here based on these data and coming out of the pandemic. And then again, we wanted to assess interest in and barriers to potential low cost or even pro bono mental health service utilization. So some of the key findings in terms of descriptive patterns. To interpret these, you have to remember that this survey was conducted between, I believe, June, July, and August of 2020. So this was early on in the pandemic. So a lot of the rates that I'm going to talk to you about may have actually gone up. But in terms of COVID-19 related exposure and stress, I want to highlight some of the key patterns that we observed here in red. So in the column on the left, you have the percent of our respondents reporting that this happened to them. And on the right, you have the percent of respondents who reported knowing somebody which this experience applied to. So in terms of personal experiences, you see that almost half of our sample of low-income adults in the region are experiencing a number of COVID-19 related stressors: job exposure, lost income, difficulty accessing social support, and increases in home-related stress and childcare responsibilities. As you can imagine, this is probably causal or influencing people's abilities to cope, to manage stress, and ultimately mental health and other outcomes. I wanted to also highlight in the top right corner that almost 3/4 of people knew somebody at the time ill with or directly exposed. And again, this was only a few months in. These numbers now are likely much higher. Now, in terms of folks' reaction, we included a survey called the Coronavirus Response Scale. This gave the respondents the opportunity to share with us how much their stress, their activities, and their overall well-being were affected since the start of the pandemic. And what I've highlighted for you here are, again, a couple of what I think we see as the most maybe troubling findings, is that you have 40% or more responding very early on that their interaction with family and friends and other social support decreased, their physical activity decreased, their prescription medication use decreased, and that their overall sense of well-being decreased. These are certainly troubling trends consistent with national patterns. But what we also want to take note of in the far right column is that more than 40% were trying to actively cope. And despite that fact, we're seeing troubling outcomes. We're seeing that almost 42% said their effort to cope with stress during the pandemic has gone up, and yet we're observing troubling patterns. Now, some of those troubling patterns with regard to mental health, these are just some of the key outcomes. Now, to properly interpret these findings, you have to know something about the assessment that we did. We used brief screeners in our survey. We could not formally diagnose conditions like depression and post-traumatic stress disorder. So these data are from clinical screeners. So any of these numbers would require follow-up from a mental health provider to actually be diagnosed, confirmed, and treated. Even with that said, again, we had about half of our sample reporting problematic drinking, as well as probable risk for depression. We had almost a third at elevated risk for suicide. And we had more than 4 out of 5 of our respondents meet criteria for possible risk for post-traumatic stress during this time period. These are deeply, deeply troubling trends that are much higher than any 6-month or 12-month incidence rates pre-pandemic, even for those most vulnerable, like those that we surveyed. In terms of some key relationship and violence findings, you can see that more than 2 out of 5 had worse interactions with family and friends, just adding to the multifaceted nature of stress. But the one that I find the most troubling, I think, and Dr. Menike can comment more on, is that almost 2/3 reported some sort of domestic violence in their relationship during the pandemic. So these findings are from a subset of our sample who indicated being currently in a long-term committed relationship. And almost 2/3 of those indicated some kind of domestic violence, be that psychological, emotional, or physical. Now, remember, our third aim was to start to look forward. Where might we find some positive impacts and paths forward? We did find that about 2 out of every 5 respondents would be interested in individual and or online telehealth. If you know anything about the national rates right now, or just trying to get in with a mental health provider, and Ms. Howell can comment on this more, mental health providers have long waiting lists right now. And I think these data sort of foreshadowed that last year. So what we're trying to do here is identify paths forward in terms of resources we might be able to develop for low-income adults in the Charlotte region. We also asked them on the right, what would be the barriers to the use of therapy? Now, a number of barriers were listed. We highlighted those that are most common. Not surprisingly, you see cost, but you also see health-related factors or health-related concerns. And that's really a broad category that includes things such as concern over being infected, concern about having to confront physical and mental health concerns, discomfort that way. So it's a broad category. We also asked folks what they would like to see if we were to design new groups. And by far, the 2 most common topics were actually financial literacy training, probably because folks were experiencing quite a number of financial difficulties, as well as coping skills training, which I think is less surprising given what we've seen and what we know generally about stress responses. So with that, I'm going to open it up to our panelists to each comment, provide some brief comments, and then we will open it up to a Q&A. So UJ, do you want to take over?
Yeah, thanks, Rob. It was really interesting to go through this work. So Psychology for All, which is a nonprofit, as Jan introduced us earlier, started back in 2015, and it was a series of local providers. So with Southeast Psych, some folks with the church group, and some other local business people who saw the need and the major disparity, I think, between access to mental health services and the disparity between sort of the haves and the have-not. I mean, therapy is not cheap, I think, for those who have had it or who are involved in providing it. So we saw this gap to bring a solution to the community. And so in 2015, Psychology for All was born, and it took a few years to really build the rails and build the network and everything we needed to be able to serve people in this very sensitive way. And so we've been operational now since 2015, but really last year was our best year. We were able to serve 35 people in this population that Rob mentioned. So these people that are underserved, under-resourced, happens to be a lot of Black and brown people, low-income people, and who don't have the access or the awareness to these resources. the opportunity to work with the team at UNCC was actually quite fun. We'd used we as in the team at Psychology for All, we used general data, and we used some information from the Mecklenburg County Community Health Assessment that listed mental health and access to mental health care as part of the top two health issues in the sort of the county. But we hadn't done anything specifically on Charlotte and so in the surrounding areas. So this was really good for us to kind of hear from our own sort of the people we serve about how they're thinking, feeling, and believing about, with regards to their mental and emotional health, especially in the context of a pandemic. So we were fortunate to get a grant from Cardinal Innovations, and we were able to then use that grant, a part of that grant, to actually work with Rob and team, and also to continue to provide the services to people who don't need it. People who need it but don't have access to it or even aware of it. What we're doing now currently with the study, Rob mentioned just the big opportunities with coping skills, and really just knowing that there are resources for people at sort of, at this point in the on the economic spectrum, I would say, in terms of income and affordability. We want to make sure that people know we're here and we're here to serve them, and that you don't have to worry about the cost being a hurdle. And also, we're trying to make sure that people are aware of just the fact that there are resources, and for mental health. There are stigmas that people have to work through. We noticed that, I think, in the survey as well, that there's stigma, that cultural stigmas and other things, and we're trying to sort of help sort of break through those barriers, those walls, if that's the right set of words, to just sort of let people know, hey, there's help, and the help is accessible, and the help is actually free. So please take advantage of it. So we're really excited. We're really thankful for this work, and we look forward to actually building on this in terms of the work we do now, but doing some additional targeted studies now that we're farther into the pandemic, and we know for a fact, I believe, that mental health has declined significantly since, probably since we published the survey. So I'll stop there.
Yeah, and as a provider in the community, I was really excited to hear about the research that UNCC and PFA partnered to do, because throughout the pandemic, we've been getting requests for talks at schools, and they want to know, how is COVID impacting Charlotte, and that has been a question. And so to know that you guys have studied that in our community is really valuable information for us to have. And it does mirror what the CDC has reported, and what we're seeing as providers, that anxiety and depression have skyrocketed for individuals who used to not necessarily struggle with mental health concerns, and that the pandemic has created a good bit of stress, that our intake number ratio, like per the amount of providers we have, is gone up, and not just people at my office, but other community providers that I refer to, right? That everybody is filling up, that there are wait lists. It's been harder to get in, connect with psychiatrists when a client needs both, or waiting lists for IOP programs. I work a lot with adolescents, and when they're in crisis and they need treatment that's more than just an hour a week, they need IOP, PHP, residential. Those local agencies and organizations have had wait lists. So the need has definitely increased for mental health care. And I think I love that. I think what you guys are starting here, it seems to be some more community collaboration, and the pandemic did reveal that need to us as a practice, because early on in the pandemic, we had an initiative that we sent out to some of the hospitals with Novant and Atrium, that we were offering. We had a list of providers at our office who had agreed that they would give pro bono services for people who had been diagnosed with COVID, or to any healthcare provider, whether they're admin staff, a nurse, a doctor. And we were offering this, but didn't have a way to get the word out, and tried to get it out as best we could. But just seeing that there is some more collaboration happening is exciting, because something like that could reach more ears and help more people. And I think on my caseload, I just had one nurse who ended up coming through that avenue, and was able to support her with just the trauma of the pandemic and the stress that healthcare providers were under, but also just do some beautiful work in her own previous like trauma history. So definitely what we're seeing as trends as providers is aligning with the research that you guys have shared. I think an interesting perspective I have is that I work a lot with adolescents and as well as adults. And this research was done with adults, but there is a trickle down effect on the impact that's had on teens in the community. If there's, already stress in the family dynamic and these kids are now at home, they're not going to school, they have no relief from the home conflict that was happening. And I did see a disparity too when we're talking about social determinants education, that kids who might be going to private school where their schools were in person, they got to go back, they had their social support again, they got a break from home dynamics if they were difficult. And kids who didn't have access to certain educational privileges they were more stuck at home, struggling more, seeing them decline more, feeling more isolated. And then there's a layer for LGBTQ youth as well, that if they're stuck at home if they don't have a validating environment and they're not connected and might even feel stuck in their house if they don't have transportation, very isolated. So many layers to how this research trickles down and impacts the minors in our community as well. So those are just my initial thoughts, and I know we'll keep jumping in. I don't know, Annalise, if you want to jump in.
Yeah, thanks, Elise, and thanks, BJ and Rob for sharing the results. I'm a researcher who focuses on violence, both on violence prevention and response, and how we can have comprehensive, trauma-informed, intersectional responses for everybody in the community. And so when we saw these findings, I definitely was alarmed that the rate of domestic violence that was being experienced in relationships was 63%. That's so high. But also at the same time, like when I took a step back and thought about it, I'm not surprised, because in the United States, particularly, we know that during these kind of very stressful situations that are happening nationally, when we see economic recessions and other things, domestic violence spikes. And that is not at all to say that domestic violence is totally explained by stress only. There are certainly other characteristics and contributors to it, but it definitely is in alignment with what we know about violence in relationships. And also what I think is important about that number, to contextualize it, is that that number represents both people who were victimized by violence and people who perpetrated violence. So we had rates of both and we combined them. And so that really kind of says a lot about what's going on with folks and their willingness to talk about these things in these surveys. And, there's historically an underreporting of perpetration in survey research. And so having some context for that and really thinking through what the implications are for practice, like, what does that mean that people are more willing to disclose that they're perpetrating? Does that mean they're wanting to get help or wanting to find alternative ways to deal with the stressors that they're experiencing? But also, like, thinking about what this time meant for us when we were in the heart of lockdown, when things were really closed down, when only essential workers were the people that were leaving their home environment. What that means for many people who were victims of domestic violence is that they didn't have a place to access help. It was much harder for them to seek help, whether that is calling a hotline or going online, if the person who is perpetrating abuse against them is around them all the time and they are stuck at home all the time. So their home environment became much less safe for them. They didn't have the ability to access help. And so what happened is we saw that access to shelters was declining because people couldn't get there. And also shelters had to have COVID protocols, so they had less beds to house people even. And so just thinking about the whole trickle and what that means for families, and then thinking, as you started to mention, what this meant for our youth and children, we also saw increases in the rates of child abuse, but at the same time, much fewer formal reports to CPS because those youth were not in schools or in places where somebody else could observe what was happening. And so there's lots of lots of implications for practice, but also the thing that I keep thinking of is, as we talk about social determinants of health, like how can we have structural responses to these issues? How can we structurally get the word out that there are services, or have responses that are more than just the individual response, because this is clearly beyond the individual problem.
Okay, I think with that, we're probably good to open it up for questions.
Yeah, Rob, let me add one thing real quick. The
Sure.
report is actually now, the report is at Psychology for All. So there's a summary, but then there's a link to the full PDF of the report actually. So we were able to get that uploaded.
Great.
People have questions, they can either unmute themselves or they can type something in the chat. And thank you all very much. This is very interesting work. And it would be great actually if you could do it again, since it's a year later. And I'm wondering now, there's been almost, there's been a much longer term impact. And
Yeah.
what
Yeah,
that might look like.
I'll tell you this, and I don't think Rob, I don't know if I shared this, but we actually just got a grant from I believe it's the Mecklenburg Bar Association. And so I think that should enable us to do a follow-up study, now that we're a lot further into this pandemic, and we're actually, it looks like we're on the other side of it in some sense with vaccines adoption and so forth. So we'll be talking, Rob.
Great. There's a question in the chat. What was the method of delivery? It was online. So there's lots of caveats to the generalizability, right? Built in, inherent to the methodology, folks had to have technological access of some kind. Even though we partnered with additional recruitment like C4 Counseling and Time Out Youth, the folks who filled out the survey still had to have some kind of technological access. So that is an important thing to keep in mind when interpreting these findings and, reaching people who we're going to serve. It really is a conundrum, on the one thing, it's great that we can get this kind of information so quickly. And on the other hand, when we're thinking of where we go next, online services versus in person, bringing services to people rather than expecting them to access them online or come to some clinic, it's kind of hard to reach everybody. I think that's the point of the, social determinants. So technology access is definitely at play, even in interpreting our findings and making use of them.
Yeah, I would just add that for some people, if they have the technology, it's great to have that sense of confidentiality. If they can do online mental health counseling in their home, they don't have to go anywhere. No one sees them enter an office or anything like that, a clinic. But then on the flip side, the people who probably need it, who experience some of the greatest stigma culturally or from their family, are the least able to use that option. And so, so we know there's a bunch of issues that way, which is,
Yeah, it was interesting. Last year, as I mentioned, we actually were able to see more people, because prior to sort of the pandemic, it was all in person, but because obviously with the shift to teletherapy, that actually allows us to see, to really serve more people, which was great, because that's what you really want. And whether it's transportation, finding a provider who may be within sort of a relative proximity to where you live, and or those were some hurdles, and we were able to, I said, to kind of climb over those with teletherapy. But I think, Jen, to your point, there may be some additional hurdles there for people who may not be able to sort of get away even for something online. So we have to sort of think through that as well. And we still have the option for people to, well, not now, but we will have the option for people to be able to go and visit with a provider as well. So maybe that will address what you mentioned.
I think that's a great point, just how telehealth, it can open up services. But speaking specifically about domestic violence, I had some people drop off my caseload when I was telehealth only, because they couldn't couldn't talk about their circumstance safely in their home. So for some people it feels safer, for others it's not as safe, and the therapy isn't as effective. Yeah. And I think there are some, we did see a delay in some people seeking services who did need them because they were nervous about telehealth, particularly with a couple of eating disorder cases where they could have started to receive services sooner, but when that's if somebody has an eating disorder, they need to be starting treatment pretty immediately. They can't be waiting. And so the people delaying services when they need to be getting into the office, and or people afraid to come back to the office when in-person was available. And if they're a high risk category, they need a risk assessment. Those are so much more effective in person. We can do it with telehealth, but it's when somebody isn't safe, it's much easier to help them ground and know that they're safe when you're with them in person. And just being able to monitor other things, like if there's weight loss or they're in critical condition. So,
well, for me, social determinants that I think this survey highlights are domestic violence, financial need, financial literacy, partially because of the self-selected sample, and then access, period, and the hesitancies to engage either in person or coming out. I'm wondering if the panel has any thoughts about where we go from here. I mean, we made recommendations within the report that, again, Dr. Thompson was kind enough to post the link to. But as we're hopefully coming out of the pandemic,
right,
from the standpoint of somebody with violence prevention expertise, Annalise, or Elise with someone with a wealth of frontline experience with mental health services, are there other things that we can design, devise, implement? You know, what are our next steps coming out of the pandemic to try to tackle some of these issues?
I think a big thing that has been on my mind is community groups. Like, people have been so isolated, and there's been a lack of support. And there were so many times where I wanted to get a client connected to more groups, more resources, and having some centralized, and I don't know exactly what that looks like. And Rob and I were having a conversation about, right now we don't have a teaching hospital. Hopefully that's coming with the Wake Forest and Atrium partnership, but that soon we would have more of those education-driven services that can be a huge value to the community in that way, where there might be different groups running and clinics, more community clinics, and access to services in that regard. And I know you guys had made recommendations about groups in the report.
Yeah, and I can just add a little bit to that around from a violence perspective. I'm really encouraged with the direction that the Mecklenburg County and the city are headed right now with adopting a very large-scale evidence-based violence interrupter program to target the high rates of homicide that we've been having in particular parts of the city. And what I really hope that can expand to is the idea that violence across all forms is connected to each other form of violence. And so if we have a gun violence problem or we have a homicide problem, that's going to be linked at some level back to childhood trauma, to domestic violence, to sexual violence, and really looking at how we can implement a comprehensive violence prevention program that really addresses what are called shared risk and protective factors, many of which are alignment perfectly with the social determinants of health. And so if we can find a way to cross-cut all of those things and be responsive to community needs, we'll see leaps and bounds gains across all of these mental health outcomes, but also violence is its own important outcome that we want to prevent.
That is one structural approach that Charlotte-Mecklenburg can take, really taking a CDC defined approach to violence, because it does. The shared risk model tackles things like domestic violence, self-directed violence, so suicide and self-injury, all in the same umbrella, tackling things like alcohol use, financial strain, employment, a lot of the social determinants that we're talking about. So I couldn't agree more. And that's the big directional shift I hope we see regionally. There's a question, what can we make from, there was a study published, I think just today or sometime this week in Lancet Psychiatry. 1 in 3 folks, I think, diagnosed with COVID experienced a neurological or mental health condition. Now, I am not a medical doctor. I am a PhD, so I will not comment on the neurologic stuff. It is outside of my. What we can make of it is I don't think it's going anywhere. I think, interestingly, the suicide rate went down in the last year. The suicide death rate at the national level. So we have all of these troubling findings about mental health diagnoses and things like that. And then this one outcome, which seems to have actually gotten better. So I think what we can expect is mental health to continue to be a tremendous challenge. And at the same time, what you see, there's some interesting literature to show that in times of mass disaster like a pandemic, collective resiliency and collective support mount. And what that enhances is the best protective factor we have for things like suicide, which is social connectedness, which probably partially explains our reduced suicide rate, yet all the challenges we're facing. I don't know if anybody else had comments or thoughts on that. 1 in 3 COVID sufferers are being diagnosed with mental health problems.
Yeah, I mean, the only thing I'll add to that is that because the way that racism and other isms intersect with our healthcare system, what that means for low income Black and Brown people is that they are probably going to be undiagnosed, misdiagnosed, or mistreated because of the way that they're presenting symptoms. And so if somebody is presenting with mental health symptoms, which I think this article also talked about some kind of psychosis related symptoms, they could be at risk of being harmed by the police or other medical systems because of the way they're presenting, which is directly effect of experiencing COVID, and that was differentially impacting Black and Brown people. And so without looking at the impacts of race and poverty on this, we really are kind of setting up the next generation and continue generations to experience harm at the fault of the system.
This is Mike Kennedy. In the short term, what would you ask people to start to do? I mean, given the whole environment that you guys have so well described, but just so we don't feel paralyzed by it, what would you recommend some of the things that could be done?
At the system level, I would put some onus on entities like UNC Charlotte and Atrium to establish community clinics. I'm a clinical psychologist by degree. Most PhD programs in clinical psychology have low cost sliding scale clinics attached to the institutions. And UNC Charlotte does not, and it should. Those kinds of clinics are becoming more and more interdisciplinary. When you have a campus like UNC Charlotte that has training programs in nursing, clinical psychology, social work, and then you have this influx coming in with the partnership with Wake Forest and Atrium, there's a lot of potential to strategize around geographic location and need and removing barriers to interdisciplinary service provision. At the individual level, I would say anything you can do to get more comfortable with telehealth, I think is going to be a positive thing, because that shift was on the rise nationally before the pandemic. All the pandemic did was accelerate it.
Yeah.
My initial thoughts.
Yeah, and also knowing that many telehealth or just mental health providers we are vaccinated and can wear masks in sessions. So in-person sessions are becoming more accessible again. And just know by word of mouth from colleagues and around the community that telehealth is here to stay. Some people have switched to telehealth only. I think and I'm more at the individual level than a systems perspective, but I think at the individual level is learning how to re-engage with people again in any way you can. Like the pandemic from a trauma perspective has put us in survival mode, and that does a lot to our nervous system. Probably everybody has had increased stress, cortisol released into their system over the past year, and having social support is a buffer against that, the impacts of trauma. And I think slowly re-engaging, paying attention to our bodies, calming, learning to relax our bodies again after a year of a lot of threats. Those are just really small ways that we can take care of ourselves.
And I think from my perspective, I'm a business guy, marketing consultant, but I am involved with the nonprofit because I think the needs are there. And people should know that there are organizations like Psychology for All out that are existing that, have the resources to help them out. I mean, we have a network right now of 15 providers from folks at Southeast Psych and other individual and other psych practices in the area who are who are willing to provide these services for free, and we work with them through our partnerships to offset some of the costs, but their help is here, and take advantage of it. Go to psychologyforall.org, and we've got the forms there to become to sign up to be a client, and we've got a team that sort of evaluates every application relatively quickly and get folks partner up with a provider that can meet their needs. So we're here, and we're fortunate to have money. We want to spend it, so send them over or come over, either way.
I think
there's an important comment in the chat about I think the added stress and anxiety of a lot of racial unrest and Black Lives Matter, and I'm sure this week also just sort of the reliving of the trauma from the killing of George Floyd, because the trial against the police officer is on.
Mm-hmm.
And so, I mean, all that conversation, which sometimes can be healing, and at other times is, exacerbates things as people get more anxious and are not seeing progress.
It can be re-traumatizing. Yeah.
I think one other thing we can do at the community level, there's really interesting data that comes out periodically in the suicide literature. So many people who attempted or died by suicide had contact with their primary care provider within 4 weeks of dying or making an attempt. I think screening as a preventive measure in key places other than mental health offices, and so training workplace management in recognizing these things. It's a idea called gatekeeper training, or in the violence arena, I think it's bystander if you witness things. But also implementing routine clinical mental health screenings in other types of provider settings, because we all, for the most part, get some kind of health care in a given year. If mental health screening can become part of that routine holistic care, you will be able to identify people that in need of services a lot more easily. There's a question also in the chat: has anyone evaluated the mental health of frontline workers? Yes. There's burgeoning literature coming out of places like the VA. And as you would expect, frontline healthcare workers, like your emergency department nurses, or are among those that are at the most escalated risk for burnout, social isolation, trauma, secondary trauma. So yes, when you layer that on to the other stressors that you see maybe in like our survey, that is a population in need of a lot of support right now from a healthcare system and employment perspective.
I think another, from a systems perspective, is you mentioned earlier just how UNCC, you guys don't have a clinic, but right now you do have UNCC and Wake Forest and Winthrop and Gordon Conwell Seminary. They all have clinical counseling interns in the community who might be offering low-cost services, but it's a very scattered network. And so there are those services happening, but again, in Charlotte, it feels very disjointed, that there isn't a lot of communication. And I think some collaboration between the different mental health programs in the area could also greatly benefit our community.
I think that's the thing that I hear from this, and Jan, I know it's time to start wrapping up, but the thing I'm hearing from all of this is like, if there was a way to compile information about who is providing free and low cost services, that could be a rotating list. And I mean, it feels like that's something that would be really appropriate to house at the university. And then we can use some of UJ's marketing skills to get the information out. But it sounds like there are opportunities, but it's a matter of people not knowing where those opportunities are at the time that they need them.
It's a big part of, Rob, real quick. That's a big part of what we're trying to do, because if you look at our mission, it's not just about access, but it's about awareness. And so one of the things I'm trying to drive my team to do is to say, okay, I think we're doing a pretty good job of getting people access. So we've got the network of providers. We're working through some of the organizations who are meeting, who work more closely with the folks who want to talk to. But I still don't think a lot of people know us. I still don't think a lot of people are aware that we're here, and we're, you know, we want to help. So we're doing more with, we call it, I mean, you might call it market. I just call it awareness, making folks aware of the fact that you can, this is something that can be addressed. There is help, and you don't have to sort of live with this, right? And sort of live in this quiet desperation. And so that's a big push for us. And part of why I'm here is hopefully to spread the word to everybody on this call, to say the organization is here, and we want to help. So if you know of anyone who could benefit from our services, please, refer them over.
Well, I think this gives us a very clear public health next direction, and that's the idea of awareness campaigns. In the college mental health literature, there's a lot of good data to support these awareness campaigns of on-campus services for student, faculty, and staff. And the same idea can be applied to a community context with available services and organizations like Psychology for All. So I think that's probably something that could come out of this. If you have a centralized hub of information that you can then disseminate through social media, old school TV and radio. Some of us still listen to the radio in the car. I mean, you know, I think that's an avenue that can have a wide impact in terms of breaking down barriers, getting information out. And maybe with creative marketing and messaging, destigmatizing services for issues like domestic violence, mental health, coping strategies, and financial literacy.
Yeah, I'm gonna just provide a couple of comments to wrap up, and then I'll give everybody a last minute or two. I think this has been a really enlightening study. I think we knew that there have been significant mental health issues in our nation, and certainly probably in our community, that were undiagnosed and untreated prior to the pandemic. So of course, the imposition of a pandemic just made things worse. And I think this has really highlighted some of the new or increased issues around, anxiety, agoraphobia, for many people, the inability to process their grief at loss of friends and family members. We haven't had our usual rituals. Certainly relationship issues that have been sort of brought to the forefront by being isolated at home. And we've touched on several issues today related to, increased violence, isolation, the inability to go to usual safe spaces. And for victims and maybe for perpetrators who, need to get away from a situation to calm themselves down. So this has been a really interesting session and really great work. I'd love to hear just a couple of closing sentences from each of the panelists before we sign off. Rob, do you want to start, or you want to be the anchor?
I'll go, and I'll just say, much like UJ was saying about PFA, especially here in College of Health and Human Services, so that's School of Social Work, where Annalisa's housed, or Department of Public Health Sciences, where Jan and I and a bunch of us are. We do a lot of community engaged work, and we're eager for more. So if somebody, if attendees from this conference think there might be partnership to be had, that can be solution focused for the region, reach out to us. And as the pandemic is coming down, I mean, I'm partnering right now with law enforcement, Department of Corrections, Navy, nonprofit like PFA. I'll meet anybody, anywhere, anytime. So, you know, if there's partnership and solutions to be had, just feel free to reach out to us.
Yeah, and I'll say that we are expanding our focus on partnerships because we realize that the people we want to reach is probably very hard to reach them directly, but we can reach them through, you know, inner city counselors or caring or a shelter or domestic violence facility or different folks. So we're really expanding. So if there are any folks here who are involved with those organizations that are serving these people that the population we really want to reach, and the population where the needs are certainly the greatest, yeah, get in touch with me or with Rob, and we'll love to explore a way to you know, to partner and support the people you serve.
I don't have a lot to add in addition to what we've already shared, but I think this has just highlighted, like, individually that we need that social support, and that's what can be a buffer against so many negative effects on the individual level. But I think that support and connectiveness on a community level is going to help us recover from the pandemic. And I think it's great that these partnerships are happening, and I know that we want to continue to be a part of them. So as providers.
Yeah, and I'll just say that I think that, you know, when you see the results of this study and hear the voices of people who have experienced all of the issues related to COVID, it can feel really upsetting. But actually, after having this panel and talking with everybody, I actually feel a little bit of hope from it. Hope in knowing that people recognize that they're in a place where they need help, know and want to get that help. And then there are folks like you, Jay and Elise, who are able to provide that help for people who can't afford it or don't have health insurance. And so that really makes me feel hopeful. In addition, I really think that this highlights the importance of the university and, you know, advocates and folks like us who are in the positions of power to really work to dismantle the systems that allowed this to happen in the first place, so that it doesn't happen again the next time there's a pandemic, the next time there's racial unrest, the next time these issues come up that disproportionately affect people who are low income. And so I think both things can be happening. We can be addressing the needs of people who are experiencing harm, but also working to dismantle systems that got us here in the first place.
Michael, I think it's your turn.
Great. Thank you, Jan. Thank you, the panelists. What a way to close out our time together today. I know it's been a long day, but it's been a very energizing day, particularly given how we were able to tie in so many of the themes that we've been seeing into this very important topic of mental health. I think many of us worry about our own mental health, and this is a way of putting all that in perspective. So I want to just conclude by thanking all of our speakers and facilitators and panelists today for so generously giving of their time and helping make this AFI Nexus 2021 such a success. So please give them a shout out in the chat or the next time you see them in person. Hopefully that won't be too long from now. Likewise, I want to make sure I thank each of you, particularly those of you who persevered and have been with us throughout the entire day. I know even with the breaks that we've had in between, Zoom fatigue is real, and appreciate your endurance and seeing the value and hopefully what we're offering. You know, we did get a chance to spend some time together and celebrate National Public Health Week. And remember, it's only with your energy, your enthusiasm, and your commitment that we can answer this call to action and make a difference.